Let me now introduce the first speakers. The first speaker is Guillermo Ambrosio, who's a junior statistician, and he works at the Guatemala Epidemiological Research Center in Sexual and Reproductive Health. And he's presenting his case together with Carla Hemming, who's a senior lecturer in medical statistics at the University of Birmingham, and she's internationally recognized for her expertise in step-wedge cluster randomized trial designs. So welcome, Guillermo.
Thank you. Good morning. I'm going to present the Guatemalan study. It's called Que vivan las madres, venga a tener su parto al CAP. In English, it is long live the mothers, have your delivery at the public health center. The four outcomes that this study targets is neonatal mortality, neonatal morbidity, mother morbidity, and institutional delivery. Neonatal mortality in Guatemala is quite high. It's 22 per 1,000. And in the two regions that the study was deployed is double of that. In these two regions, 75% of mothers give birth at home. They usually prefer traditional birth attention, and they don't trust much in the public health facilities. Also, the public health facilities in these regions, these are rural regions, are very basic, and they cannot attend much pregnancies. They only do vaginal deliveries, and they often don't have enough equipment. So this study started in 2014. It includes 33 municipalities. It was selected to be a step wedge trial in order to deliver the intervention to all of the 33 municipalities. The intervention has three arms, three branches. It's social marketing, pronto training, which is based on simulations, and work with traditional birth attendants to work better with the public health facilities. One of the main objectives was to promote institutional birth, and the other two, that was decreasing the morbidity and mortality outcomes. The intervention consisted on the social marketing campaign that encouraged women to have their deliveries at the health centers. It included posters, radio ads, television ads, also a number of promotional materials. The pronto training is culturally sensitive, and it was very well accepted by the health personnel. It also included the participation of the traditional birth attendants, and it attempted to get both sides, traditional and public health, to learn from each other. There was also work in the communities with traditional birth attendants and pregnant women. And these are the three branches of the intervention. This is the design of the study. We had 6 geographical zones, 3 for each of the 2 districts. Each of these zones has from 4 to 6 municipalities. Each of the periods of intervention lasted for 4 months. Now I'm going to leave you with Carla Hemming.
So I'm going to discuss some of the ethical issues that this study raises and other similar studies like it also raise. So the step wedge cluster randomized control trial, it's seeing an increasing amount of use, a sort of exponential increase, if you like, especially in lower middle income countries. In a recent systematic review looking at all of the stepped wedge trials that had been published to date found that only about half of them reported that they had undergone research ethics review, and very few reported from whom informed consent was taken, and almost all lacked details on what the consent was for. In addition to this, only about half of these studies were pre-registered on a trial registration database. So current ethical guidance is mainly stems from guidance on interventions that are individually targeted at a particular individual, like therapeutic interventions. But there is some guidance on the ethical conduct of cluster randomized control trials, namely the Ottawa Statement. And although a stepped wedge trial is only a subset of, or one particular type of a cluster randomized control trial, it at least gives us a starting point. Now, the Ottawa Statement very helpfully, clearly differentiates some of the very important aspects of the appropriate ethical conduct of cluster randomized control trials. One of the very important points it makes is that it's important to identify who the human research participant is. And we discussed this a little bit this morning in the cluster randomized control trial case studies. And essentially, the Ottawa Statement says that actually often it's the healthcare practitioners who are the human research participants, and they are the direct target of the intervention. And this is because of the types of interventions that are evaluated using these trials. It also tells us that the individual patients are less likely to be the human research participant. This is unless they are the direct target or the indirect target of the intervention, or their private and identifiable data is collected. It also outlines when it can be appropriate to have a waiver of consent. And essentially it says that a waiver of consent is appropriate if both the trial would not be possible without the use of a waiver of consent, and if there are only minimal additional risks of participating in the trial. So I wanted to think about some of these issues for stepped wedge trials. And one of the first issues that I wanted to raise is whether these studies should be considered as research or not research. Now, the fact that only about half of these studies reported that they had research ethics committee review suggests that many researchers feel that these studies are not research. So perhaps it might help to go back to the definition of what research is. And one of the definitions is that the objective is to produce some generalizable knowledge. Well, all of the studies that we're talking about, or that were used in the review, they were actually published. So perhaps arguably, they were fulfilling that objective of producing generalizable knowledge. And the other point to consider is that stepped wedge cluster randomized control trials are randomized evaluations. So does not the act of randomization give us a sufficient reason to believe that these studies are also research? But actually, we need to perhaps think a little bit more carefully, because one of the very compelling reasons for using a stepped wedge cluster randomized control trial is that this intervention that we're evaluating is going to be rolled out irrespective of any evaluation. And the researcher intervenes insofar as agrees or persuades the stakeholders to allow them to randomize the order. But actually, very few of the stepped wedge trials reported are of this particular form. And most of them are actually evaluating interventions that would not have been rolled out outside of the study. So perhaps we might think about whether the trial that Guillermo is talking about was research or a service evaluation. Well, arguably, that intervention wouldn't have been rolled out outside of this trial. So the second issue that I wanted to raise is whether it's justifiable to delay the rollout of an intervention. So perhaps if we remind ourselves of what the stepped wedge cluster randomized control trial is, it's a randomized rollout of an intervention. Ultimately, all clusters receive the intervention, but some of the clusters will receive the intervention earlier than other clusters. So there will be a delay in the rollout. In addition, not all participants in the trial will receive the intervention. If it's a cross-sectional stepped wedge cluster randomized control trial, as in the Saving Mothers Guatemala example, not all participants, not all mothers will receive this intervention. Now, one of the top reasons for conducting or using a stepped wedge cluster randomized control trial is the belief that the intervention is going to do more good than harm, a belief that the intervention is going to work. So if there's a belief that the intervention is going to work, is it therefore justifiable to delay the rollout of this intervention? But we could also flip that around and think, is it justifiable to do a randomized evaluation if we believe this intervention is going to work? So there's a tension here between clinical equipoise, perhaps, and evaluating an intervention that we think is going to work. Although perhaps we don't necessarily have to believe that both of these things cannot stand together. It may be the case that there's uncertainty, and so clinical equipoise, but at the same time, we may have a slight belief or a hunch that one of these interventions is going to be better than the other. So back to the Pronto example, was it reasonable in the Guatemalan study to delay the rollout of this intervention when actually there was evidence that the Pronto intervention was going to be effective? And then the third question is the identification of the human research participants. So the Ottawa Statement tells us that we have to very carefully identify who are the human research participants. And the intervention that we're talking about in the Guatemalan study had several components. One of the components was a training of the health professionals. The training of the health professionals were therefore a direct target of part of the intervention, and so arguably the human research participants in this trial. So should the trial have obtained the consent from the healthcare research participants? But actually, our systematic review has shown us that very few stepped wedge trials and very few cluster trials are actively identifying the healthcare practitioners as the human research participants. But there are other broader issues of consent as well. So in the Guatemalan study, there were other components of the intervention, and one of the components of the intervention was the social media campaign. And so perhaps arguably the target of that component of the intervention was the individual participants. Their data was also collected and used in this evaluation. And so both because they were an indirect or direct part of the target of some parts of the intervention, and because their data was used in this evaluation, should the individual women have been considered the human research participants? But then does that make the study infeasible if we include all of the women as human research participants? So perhaps then we can go back to the Ottawa Statement and find a justification or identify that there may be a justification here for not taking the consent from the individual women, because that would have made the trial perhaps infeasible. So those were the 4 issues that I wanted to discuss. Thank you.
Well, thank you both. Just some room for questions of clarifications. And then the next speaker, yes.
Sorry, thanks, Carla, for your interesting kind of like talk. I think one thing that we know already is most of our trials are futile, which means the intervention that we investigate are not good enough. Secondly, 50% of the stepped wedge design trials, they are futile, which means the assumption that you are saying actually maybe we will end up rolling the intervention to the rest of the participants is a bit misleading, if I can say. So are we overselling the stepped wedge design using the wrong information? What are the ethical implications for that as well? Thank you.
So I think that perhaps in part the answer to that is that what we're saying here is these are the reasons that people are using the stepped wedge cluster randomized control trial. And I don't think that we're necessarily saying that we're endorsing those reasons, but that perhaps we should think of it as an alternative trial design that we might consider if we think perhaps the parallel is not feasible.
Other questions? No? Then I'd like to thank Carla and Guillermo.